Welcome to AETCM, the Emergency Medicine channel. Today's our topic of discussion dementia and the neoplasm from the chapter of neurological emergency. So first one is a dementia. What is mean by dementia? Dementia is a chronic deficit of memory, personality, language skills, perception, reasoning or judgment. The major important thing without losing the consciousness. So simply we can remember as it is a memory loss related thing. So the person will forget regarding the memory, personality, language skills, perception, reasoning or judgment related thing. So the main important key factor is without losing the consciousness. So these changes can occur over a weeks to year, and it can be a subtle changes also. So the disease may progress from the weeks to years. Subtle means so that is not easily identifiable, that is called subtle. Okay. So before that, getting into the dementia, we have to know about the various stage of consciousness. So from the consciousness, what are the various stages or various forms of the consciousness is there. First one, consciousness. Consciousness means being awake and aware of both oneself and then environment or surrounding. That is called the consciousness. Second stage or next stage is a clouding of consciousness. It is a mild form of altered mental status. Third stage is a confusional stage. So here only our dementia will take comes under here only. So confusional state means there is a profound deficit including disorientation and difficulty in following commands due to focal deficit in cognitive functions. Okay, that is called a confusional state. Here only our dementia will come. So fourth stage or next stage is a upturnation. So here the person lessened interest in the environment, slowed response to the stimulation, they are more tend to the sleep, they are more prone to sleep. And then fifth stage is a stupor. Here with only a vigorous and then repetitive stimuli only the person will arouse. So the person will awake. Until unless he won't awake, he also will be in a sleep mode. So coma is the next state. It is a state of unresponsiveness. Patient can't be aroused even with a vigorous or a continuous stimuli also he won't respond. So that is called the coma. And then last stage is a persistent vegetative state. Here the person is awake but unaware about the environment. So this the patient is awake but unaware about the environment. So these are the various stages of consciousness. So this is about the different types of dementia in different disorders. So we have 6 major disorder: Alzheimer's disease, Pick disease, Huntington disease, and then Creutzfeldt-Jakob disease, and then Wernicke encephalopathy, finally AIDS dementia. So these are the various types of dementia in the various conditions. So first we'll see the Alzheimer's disease. So cause for the Alzheimer's disease is so for all 6 cases, there is a one root cause, the one root cause for the dementia. So what is that means? Damage or there will be a destruction in the neuron. That is the one root cause for the every disease. Otherwise, one root cause for the dementia. So damage or destruction of the neurons. Okay, this is the root cause. So by this we are seeing Alzheimer's disease. Here how it is affecting or how it is damaging means there will be a development or build-up of the block in the neurons in the brain that will causing the neuronal death, that is decreasing the brain mass. So the ultimate concept is here you can see that it will develop the blocks in the brain and then it is decreasing the neuronal death. It is causing the neuronal death, thereby the brain mass will reduce. So, but the worst thing is the process begins 10 to 20 years before signs and symptom appears. So once the mass will decrease, so first the progression of the brain mass will decrease. After 10 to 20 years only the signs and symptom, the clinical manifestation will arise. So this is one of the worst thing in clinical presentation wise, chronic insidious memory loss in the earliest finding. So insidious, chronic means we know, so insidious means that disease condition or the clinical manifestation that will develop gradually, but it will tend to more severe. It will show the more severe effect in the later stage. but it will develop more gradual phase, right? So in moderate disease, there will be a decrease in attention, judgment, language function. In severe disease, there the person unable to recognize the people, eventually can't uh, communicate, and then they will become a bedridden. So second is a pick disease. The cause is unknown, but some genetic aspects also playing role in this disease. Here also the neuron damage will occur mostly in the frontal and then temporal lobe. So presentation wise, mainly it's diagnosed in the age group of age between the 55 and then 65 years cases. The presentation also inappropriate, socially inappropriate behavior. So this is the most common disease everywhere we can hear, that pick disease. Mainly these person will show a behavior of stealing and then obsessive behaviors, apathetic and then depressed state, inappropriately elated. Additionally, they have a wrist tremors, difficulty naming with even with a common object, they can't identify that object, cognitive related thing. Incontinence may be present. Huntington disease, it is a adult onset genetic disorder. So it is related with a congenital, but it onset that disease onset is it will occur in the adult stage, right? So initially the person will be in a frightenedness, abnormal eye movements will be there, tics, myoclonus, irritability, loss of interest will be there, and then bradykinesia, slow movement will be there, difficulty in standing, ataxia, slowing of thinking, memory loss also occur. And then Creutzfeldt-Jakob disease means it is also there will be a problem in the clump of protein, clumping will occur. So the clumping means the abnormally the protein will join, the clump will occur, that result to the death of neuron and damage of neuron. So it is also leading to the myoclonic jerking, major cognitive deterioration, and then visual impairment, unstable gait, ataxia related things, and then diseases. This condition is always fatal one. And then Wernicke encephalopathy, most common one, we are all aware about these diseases. So Wernicke encephalopathy mainly that will occur because of the vitamin B1 deficiency, thiamine deficiency. So the clinical presentation wise, ataxia, confusion, agitation, memory loss, nystagmus, generalized weakness, foot drop, and then peripheral neuropathy. So AIDS and last condition is sorry, AIDS dementia, that is because of the infection, AIDS HIV infection, that is creating some associated infection that leads to the dementia, AIDS dementia. Here the clinical presentation wise, blunted effect, impaired memory loss, and then slowed verbal response, difficulty in the concentration, that will progress into partial paralysis of the lower extremity, and then mutism. Mutism means unable to speak. So eventually it may lead to the vegetative state also. So assessment point, always we should not confuse with the dementia and then delirium. So delirium is a sudden state of confusion or disorientation. So both features will looks like same, but both are different. So dementia is different, delirium is different. Delirium means that is acute onset of confusion or disorientation. So easily you can remember by this statement. So if you have you have ever been to enter into the bar means, there you can be see the someone drunk and then they have witnessed as a delirium. So that is the easy statement. So if you went into bar means, there you can see the some people who the drunken people, they will be in some set of acute onset of confusion state, that is called the delirium. So by statement, by definition, delirium is a reversible one. So we told acute onset. So once after an effect, they will return back into the normal. But our dementia is a irreversible state. Okay. So so we told it is a loss of memory. So loss of memory in the sense, not alone the name address, even though they will forget about the how to perform the task or how to perform the routine daily activity also, easily they will forget. So that will end up in a furthermore otherwise worsen the patient condition. So and then they will become aggressive and then violent because of the judgment problem in the cognitive function. So and then confusion is one of the hallmark for the disease of the dementia. And then the blood glucose level, oxygen level, blood chemistry also we have to routinely check, because In one presentation also we discussed hypoglycemia that may lead to the confusion, and then hypoxia, that is also one of the major factor leads to the confusion or dementia related things. So management, pre-hospital we have to follow the standard care guidelines for the neurological emergency. So whatever things we have to give the ABCD, everything we have to manage, and then we have to think about the oxygen, and then mainly we have to consider about the glucose level. So those are the some major factors we have to think about, and then ensure no reversible causes is present, and then again we have to check the glucose level, oxygen level, blood chemistry. So think, so one presentation also we have to we deal regarding the triad. So triad in the neurological emergency. So always you have to consider the glucose level. If it is a hypoglycemia, hyperglycemia, both are danger in that case. So we have to treat both conditions. If it is a hypoglycemia means we have to follow the based on protocol. Hyperglycemia means based on the hospital protocol or insulin protocol we have to follow. And then oxygen also one of the most important thing, hypoxia, that you have to manage. Temperature, so we should not allow the patient go into the hypothermia. So that is also, so these are the three major standard guidelines for the whichever neurological emergency, whether it might be a stroke or seizure. So these are the three things we have to keep in mind. So and then Wernicke encephalopathy, it is a, this confusion and dementia is a partially reversible one. So if you are treating correctly means that we can revert easily, that case we can revert easily. For that cases we are giving the we are supplementing the thymine injection, vitamin B1, that is a thymine injection, 100 to 200 mg IV push. So here what is the role of thymine or what is the role of vitamin B1 means that will help to metabolize your glucose level. So the person may have a lot of glucose level, but but with lack of thymine means there is no use. So thymine or vitamin B1 is a key factor for the metabolism of your glucose. For that reason, if you are suspecting the person as a Wernicke encephalopathy by the clinical presentation means before administrating glucose, you just give the thymine first and then you can go for the glucose. Okay, and then in the patient vitamin B1 deficit, giving glucose actually cause the confusion and worsen the person presentation if thymine is not present. So and then malnutrition, if like a person in a hypomagnesemia, hypokalemia, hyponatremia means based on the condition we have to treat. Hypomagnesemia means we have a MgSO4, magnesium sulfate, 1 gram ambule is there, right? So that based on the deficit we can treat. Hypokalemia means again potassium chloride we have injection format, so 20 milli equivalent, the 10 ml ampule, that based on the deficit we can treat. Hyponatremia, so we have a various saline preparation like 3% and then 0.9%. So various preparation are there. So these are the things mainly carried out in the in-hospital scenario. So there we can't, in pre-hospital we can't perform all the blood serum investigation. So mainly, but in hyponatremia we try to interfere the case because usually we'll administer crystalline. So instead of going with another fluids, we can administer the ringer lactate or normal saline solution. So in hospital care mainly we have to correct the electrolytes. We have to go with an scanning, CT, MRI, neurological function test, electroencephalogram, and then based on the causes, so we deal to 6 major causes. So based on the causes we are going with a definitive management. So second condition is a neoplasm. Neoplasm, we know that is a cancer, right? So cancer means there is a abnormal growth. So what's the major thing means there is no some purpose, useful purpose for that growth. There is no such use in the abnormal growth. But what will happen because of that growth, that will that will compress the nearby organ, and then that will create the furthermore complication, or it will create the complication. So the tumor can be classified according to whether they represent primary or mets. So primary means the cancer that arise within the nervous system. Our general form if you are telling means primary cancer means that will present one part of the body. Mets means that will travel from that original pathology area to the other systems via lymphatic system or via your vascular system. It will travel to the other organ system, that is called the primary and then mets. Primary, so if you are considering this nervous system, primary neoplasm means the cancer that arise within the nervous system. Metastatic disease means from the nervous system it will spread to the lung and then breast cancer or the other sides. So that is called the metastatic disease. So the assessment wise, the person will present with a headache, nausea, vomiting, seizure, ataxia, changes in the mental status, stroke-like signs and symptoms are the most common one in the case of tumors. And then the rate and intensity of these signs and symptoms fully depend upon the cancer growth. So the growth of the cancer, the neoplasm. Okay, the spinal tumors, mainly if the person have a spinal tumors means they will show the signs and symptoms, they will show the signs, clinical presentation of compression of the spinal cord. Here the major clinical complaint, the person symptom is a back pain is one of the major clinical presentation in the case of spinal tumors. Person may also experience weakness because of the compression of the spinal cord or compression of the nerve. They will feel the weakness, ataxia, loss of sensation in the limb, incontinence and the deformity of the spine. So the main key factor in the neoplasm, because of that abnormal growth, it will compress the adjacent structures, it will compress the nearby structures, thereby it will create a clinical presentation or thereby it will create the complications. So the management wise, pre-hospital wise, majorly it is a supportive management. If the person have a status epilepticus means, then we can administer the diazepam. So whichever in a seizure condition, our first priority of drug is a benzodiazepines. Here we can use diazepam, or else if we have a midazolam means, that we can administer the midazolam 1 mg or 2 mg based on our guidelines. We can use based on our medical director guidelines. So if the person have a elevated intracranial pressure means, that we have to manage. So ICP mainly two type of management only we are carry outing in the pre-hospital. Already we discussed. I am referencing that one. The first thing is a head and bed elevation 30 to 45 degree and then hyperventilation. So 2H for the pre-hospital ICP management, elevated ICP. So head and bed elevation 30 to 45 degree, you just elevate the bed and head and then we have to do the hyperventilation. So the when we have to do, how we have to do everything, we discussed already in some other presentation, you can refer. So all the patient with a new onset of seizure or chronic headache can't be managed, need a medical evaluation. So simply we can't treat that case, we have to go with some other evaluation based on that, whether that is a primary or meds or some other cause, it is causing the headache or seizure, that we have to rule out in the definitive care. If the patient has a spinal tumor means, then we have to save the limb. How we can save in the limb by avoiding the injury means, here we mainly pre-hospital we can do the assessment only, because we can't do anything in that spinal tumors. So to save a limb, so that we can assess the PMS means, so regularly we have to assess the pulse, motor and then sensory response. So we have to assess the pulse, motor response and then sensory response throughout our journey, throughout our transferring. We have to check these are the things and then we have to notify the definitive care. If you are noticing any deficit in pulse or decrease in pulse, the tension means, then you can notify the definitive care. So in hospital management fully depend upon the where it is and then the cancer location and then type of cancer, whether that is a meds means, we have a radiation therapy, chemotherapy, lot of things they will carry over in the in hospital management. So do your best. Shalom.